Okay, this is Dr. Milliken explaining how this is a possible complication of the weight loss, and it's perfectly possible and not a big deal.
Okay.
Okay.
All right. So, like we talked about, what you had is called a Peterson hernia.
Okay.
Okay. And when you lose all this weight, you lose weight everywhere. You lose weight intra-abdominal and outside. Okay. This is a function of losing all the weight on the inside. The mesentery of the bowel, where the blood supply of the bowel comes from, you lose weight in that mesentery. Okay, and the holes that you make during the bypass to reroute bowel, those holes get bigger as that weight loss continues. Okay, so some of it's unavoidable. You know, there's just no way to go in every week and close it up. So some of it is unavoidable. This defect, or this hernia, for lack of a better word, really.
Peterson hernia.
Peterson hernia, is where those holes get big enough to the point where bowel is on the wrong side. Your small bowel had herniated up through, underneath your colon. The way the root limb went, it had all herniated up through that hole and was above the colon in the wrong spot. Okay, and it sounds like what was going on with you, where you were having pain and then you'd get a little better and you'd have pain. What was happening is that bowel was going up through there, getting stuck momentarily or twisted, so it wasn't emptying properly and causing you pain. And
I throw up because I was throwing up.
And you throw up. Right. And, perhaps it would reduce by itself, okay? Because the hole's big enough where it should go in and out, back and forth. If that's happening, no problems are caused usually. When it gets in there and doesn't go back, that's when the problem happens. And what had happened with you is yours had gotten, really all of your small bowel had gone through the hernia to the other side and had rotated 180 degrees, okay? So when that happened, it couldn't empty. So fluid keeps building up. That small bowel gets larger and larger and larger. The larger it gets, as you think about it really simply, the larger it gets, the less chance of it going back on the right side or reducing itself.
Okay.
So eventually it gets to the point of no return, which yours had gotten there. The fluid had gotten to the point where the bowel was so big it couldn't go back, and it had twisted and couldn't retwist. Okay? So the blood supply to that bowel is what you worry about, getting twisted and cut off. Okay? These usually present like yours did. Maybe a smoldering, several weeks of on again, off again vomiting, pain that, maybe
I've
severe.
had that kind of happening for even a couple months.
Yeah. That's not surprising. Like I said, it can go on and on for a long time. And it's, unless you do bypass or you deal with bypass patients, that may not be the top on your differential.
Right.
You know what I'm saying? But fortunately, I'd had a lot of experience doing bypasses in residency, and had seen a lot of patients come back to the emergency room and with these symptoms.
Does the emergency room just not have the ability to detect what's going on? Because every time I presented myself, I said, hey, I'm a post-bariatric person and my stomach is hurting a lot. I'm very concerned because I've had that surgery.
Right.
And it seems like an upper GI.
An upper GI is the test. That is the test. And I hate to pin all this on the ER or on this doc or that doc. It comes down to really your experience. And if these bypass are relatively new, I mean, yeah, they've been around for 20 years.
But people are getting them done a lot now.
Right. And the numbers of patients with this bypass has grown dramatically. And
but would they not have been caught it 2 weeks before when I had a CT scan?
Not necessarily.
Well, they were looking for appendicitis.
Right. A CT scan is a great test, but
they were going to do a CT scan on me that day that you met me, Thursday, And I told him, I said, look, I took one swallow of orange juice and threw it right up. I said, there's no way I'm going to hold down 2 large glasses of barium for an hour and a half to have a CT scan.
Right.
And then they're like, well, okay, we'll do an upper GI. Like, that was the secondary consideration.
Yeah. The CT scan is our go-to test for abdominal pain nowadays. Okay,
Right.
The CT scans are great for showing a lot of things. This particular problem, the upper GI, is the test to show it.
Right.
Because the CT may show you some bowel dilation, but you can't tell on that CT where that bowel is, whether it's in the right spot or the wrong spot. That upper GI, that contrast goes down and piles up here instead of down
Right,
here.
upper chest.
Right.
Right.
And it's the one thing where that test is the test to do.
Are they going to start doing that with gastric bypass people?
As people get more educated on the problems of after a gastric bypass, then yeah, it will get better. And if you go to a hospital where they do bypasses, their doctors are more used to seeing those patients.
Right.
So, it's hard to...
Well, I know that our local gastric bypass doctor, the one that's currently the only one, he only deals with his own patients.
Right. Right. And
so...
I can't speak to that. I really can't. But
I mean, I know that for a fact. That he
and that's
will not do
unfortunate.
that.
Because,
so
because
I have
you
no
can't always
options,
be at
it
home
seemed like. My
with your
surgeon's
dog.
in Atlanta.
Right.
So,
Right.
like, imagine me Thursday morning when you met me,
Right.
driving 3 hours to Atlanta first, or, 2 hours to Atlanta.
And, I think things just worked out well for you on this trip because the ER doctor that saw you, I know her. She actually came from Spartanburg with me where we did a lot of bypasses.
Is it Faustino?
Dr. Domers was the one that called
okay.
me. And,
Yeah.
they do a lot of bypasses over there, so she was probably more used to it than the doc you had seen previously. So it was a bit of luck, a bit of good timing
Right.
that you came in when you did.
And when you did my surgery, so basically because it did the 180 and was cut off, so there was necrotic tissue, or?
Right. And that doesn't always happen. Okay.
Right.
That was, I guess, a little extra for you because yours had twisted to the point where the blood supply to your root limb, which connects to your stomach, was compromised, and that blood supply had been cut off. So that limb of bowel, about can't see that on the tape recorder, about 12, 15 centimeters,
right,
was not viable.
So do I have different bowel attached to my pouch now than I had before?
You do. Basically, you just have 6 inches missing.
Right.
You just moved it
basically, you just took out the 6 inches that were attached to my pouch,
right,
and brought up the new healthier bowel to the
right. So the route is the same.
It's like I had a brand new.
You have a brand new anastomosis.
Right. Wow.
Right. So your root limb is about 6 inches shorter than it was, but the route's the same.
Right.
You shouldn't notice any different.
Well, I feel like I can eat. I'm eating less. I
Your
feel like
pouch
I've got
will
a new
be-
restriction.
Yeah, your pouch is a little smaller because every time you have to revise it, it cuts down a little bit on the side.
Yeah, and that's
but
cool.
it'll stretch back out to the same. And
I was just curious because I'm getting this weird stabby feeling in my ribs, and I don't know if this is this is the 3rd day, and
okay.
I don't know what the deal is, but I'm getting like a stabbing in my ribs. I don't know if it's related.
Is it constant or come and go?
Like it just hits me. Like it's like I'm being stabbed. It's not always, but like something like moving, or if I take a deep breath.
Okay.
I don't know what. I don't know if it's related or anything. But
It probably is related. It's related to the incision more than anything.
Yeah.
These nerves are coming around
Yeah.
your rib cage, and I cut pretty high. You're up to
Yeah.
the rib cage there.
Yeah.
So.
I had a question about my abdominal muscles. Of course, you had to go through them, right? So.
Well, I didn't go through your muscle. I went through the midline. Okay.
Oh, the midline, right?
Right
My
beside
plastic surgeon,
between-
when he did my tummy tuck, he sewed my abdominals back together. He said on 4 different layers.
Right.
Did you put them back together?
Right.
Like he did them?
I did.
Oh, good.
And it took a long time to get in there. It took a long time to get out because all of your abdominal wall is rolling up You know, so there's several layers.
I was packed pretty tight.
Right.
Yeah.
There's several layers to get through, but we put them back the way we found them.
Oh, good. See, that was one of my concerns
Yeah.
because my abs had seemed very tight before, and they feel a little looser now, and I just didn't know, like, if you put them back the way they were. So
Yeah.
that's,
We
that's
did.
cool. He's going to do a scar revision. He's just going to take that hump out
Okay.
and put it back because I got a zipper now. He doesn't want that in his after book, you know.
Sorry.
I
Had to
said,
be done.
screw it, I'm alive.
Yeah.
You know,
Had to be done
alive.
at the time.
So, yeah, totally.
We can always revise the scar.
Yeah, totally. Yeah, I'm getting my chest done eventually anyway, so he just thought he'd just pull up and
Gotcha.
take
Okay.
it all out. So I'm quite a project.
Yeah. Well,
Because I was big.
keeping us busy.
Yeah.
That's good. But I'm so glad you're doing well.
Yeah.
You look good.
Thank you. I am in pain because I drove here.
Those stabbing pains should go away
Mhm.
as this incision heals and those nerves get back to normal. That nerve is just firing